Hello students, this is Professor Greminger. I welcome you all to Hyperlipidemia Week. Well, in 2013 it was a big year. The American Heart Association and the American College of Cardiology published a new set of guidelines for the treatment of hyperlipidemia. The new guideline is a departure from the Adult Treatment Panel ATP3 report, which you're very familiar with, and it will replace these guidelines. So today what I'd like to do is introduce you to the new ACC-AHA guidelines and discuss how to put these into practice. So first let's review some brief statistics on coronary heart disease. Still today, over 2,000 Americans die of cardiovascular disease each day, which is an average of one death every 40 seconds. Cardiovascular disease remains a leading cause of death for both men and women and results in about 1 out of every 6 deaths. Every year, over 700,000 Americans has a myocardial infarction, and of these, about 500,000 are a first MI, and 200,000 or more happen in those who have already experienced an MI. Fortunately, in the past decade, deaths attributable to cardiovascular disease have declined 31%. And this is attributable to improvements in terms of identification and treatment of hyperlipidemia. Coronary heart disease alone costs the United States over $100 billion each year, and this includes the cost of healthcare services, medications, and lost productivity. So how does ATP3 differ from the ACC-AHA guidelines? So for years, all of us have been treating lipids to specific lipid level goals based on risk levels. So for example, patients with diabetes, we achieve or try to achieve an LDL of less than 100 milligrams per deciliter. And in patients, secondary prevention patients with coronary artery disease, we attempt to optimally treat to an LDL less than 70 milligrams per deciliter. This so-called treat-to-target approach has been used for over a decade for the treatment of dyslipidemia. However, multiple randomized controlled trials have failed to demonstrate cardiovascular risk reduction with specified LDL targets. Trials have demonstrated, however, cardiovascular risk reduction using specific statin doses at higher doses. And hence, the new guidelines were developed to address this atherosclerotic cardiovascular risk reduction utilizing more intensive HMG-CoA reductase inhibitors, also known as statins, but not to targeted treatment goals. So appropriate patients will now be treated with moderate or high dose statin therapy based on which of the 4 statin benefit groups they are assigned to. Now, this approach may seem aggressive to many of you, but the data supports it in terms of its efficacy, outcome, safety, and tolerability. Now, that level of evidence for the recommendations is highlighted in this slide, and I will be approaching this as we move through the recommendations. So now let's take a look at what the guidelines mean for all of us providing care to patients with hyperlipidemia. So the guidelines focused on 3 main critical questions: who to treat, what treatment to use, and how intensively to treat. So who should be assessed for cardiovascular risk and how should we approach this? For patients aged 20 to 79 without a history of coronary artery disease, an assessment of traditional risk factors should be done every 4 to 6 years, and these patients should be advised on risk reduction strategies. For patients who are between 40 and 75 and are not currently on lipid therapy with LDL values less than 190, they should also have an estimate of their 10-year risk of cardiovascular disease assessed using the pooled cohort equations cardiovascular risk calculator. Now, this pooled cohort equations risk calculator is an easy-to-use spreadsheet that allows us as providers to estimate 10-year and lifetime risks for developing atherosclerotic cardiovascular disease. The information required to do this includes age, sex, race, total cholesterol, HDL cholesterol, diabetes status, systolic blood pressure, use of blood pressure medications, and tobacco use. You can find this calculator at the American Heart Association website, and there's also an app that you can download on your phones, either iTunes or Google Play. Now, what happens when you input this data is that patients are categorized as being low or high risk. Patients who have a 10-year risk, which is less than 7.5%, should be encouraged to implement any necessary lifestyle changes, including maintenance of body weight, incorporation of exercise, adherence to a healthy diet, and smoking cessation, for example. Now, this tool can also be used to estimate lifetime risk of cardiovascular disease, and it's really a great tool to facilitate discussion between providers and patients about risk reduction through lifestyle change. Now, high-risk patients are defined as having a 10-year risk greater than 7.5%, and these patients are recommended to start intensive pharmacologic therapy with statins in addition to the lifestyle recommendations. So the ACC-AHA guidelines do provide us with data on who should be treated, and let's take a look at that. Okay, the guidelines have identified 4 major groups that will benefit from intensive treatment with statins. These patients are at high risk for atherosclerotic cardiovascular disease, or they already have established cardiovascular disease. So aggressive therapy will result in risk reduction, defined as a reduction in coronary death, non-fatal MI, fatal and non-fatal stroke. So who should be put on high-intensity statin therapy? These are patients with established cardiovascular disease. And when we talk about established cardiovascular disease, we're really talking about those who have had an acute coronary syndrome, such as MI, patients with either stable or unstable angina, patients who have undergone coronary or any other arterial revascularization, patients with stroke or TIA, and those with peripheral arterial disease, which is attributable to atherosclerosis. Other high-risk patients are patients with LDL values greater than 190, and this often includes those with familial inherited hyperlipidemia syndromes. Patients with diabetes but do not have established CAD, who have LDL values between 70 and 189, and who are aged 40 to 75, and patients who have an estimated 10-year risk of coronary artery disease greater than 7.5%. Of course, that's the high-risk category. Now, there are other benefits that may benefit from statin therapy as outlined in the guidelines. If the patient doesn't fit into one of the 4 statin benefit groups I just described, but there is clinical suspicion that they may benefit from therapy, additional factors can be taken into consideration. Patients who have an elevated LDL over 160 with evidence of genetic dyslipidemia, that would be patients with heterozygous familial hyperlipidemia. Those who have a family history of premature cardiovascular disease, and premature cardiovascular disease is described as a first-degree male relative who has an event younger than 55 years of age, or a female first-degree relative with an event under the 65 years of age. Patients who have a high sensitivity C-reactive protein over 2 milligrams per deciliter. Patients with evidence of peripheral arterial disease, that's an ankle brachial index less than 0.9. Those with an elevated lifetime risk of coronary artery disease, and that's done by using the calculator. And those with a coronary artery calcium score greater than 300 Agatston units, or those at 75th percentile for age, gender, and ethnicity. So in addition to statin therapy, all patients should have a routine assessment of lifestyle factors and should be advised on incorporation of diet, exercise, and tobacco cessation. In terms of lifestyle, patients should be advised to maintain a healthy or ideal body weight. You can use body mass index as a way to measure weight, looking at ideal body weight less than 25%. Anything between 25 and 29% would be overweight. Anything over 30 would be obese. Patients, of course, should be advised on cessation of tobacco. The recommendations for exercise in the guidelines are moderate to vigorous exercise, 40 minutes at least 3 to 4 times per week. And patients should be advised on a heart-healthy diet, which includes a high intake of fruits, vegetables, lean protein, including fish, poultry, and beans, non-tropical vegetable oils, and nut intake. There should be an avoidance of red meat, sugary drinks, and sweets. Importantly, saturated fat and trans fat should be reduced to less than 5 to 6% of calories, and they also do recommend limited sodium intake of 2,400 milligrams per day. So what about other therapies, non-statin therapies? Is there really a role for them? Well, what about the other agents? And what do you do if patients are taking other agents? There's not enough evidence to support the use of other non-statin therapies such as fibrates, cholesterol, niacin, or ezetimibe. These agents have not been shown to reduce atherosclerotic cardiovascular disease either as monotherapy or in combination with statins. And the combination therapy also increases risk of side effects. Now, there are a few exceptions, and one would be those patients with hypertriglyceridemia, especially those with triglycerides over 500 milligrams per deciliter, as these patients are at a high risk for acute pancreatitis. Now, just note that these patients often have a secondary cause for their triglyceride elevation, and secondary causes should be identified and modified. So, for example, make sure you evaluate for hyperglycemia, which could be new onset diabetes, uncontrolled diabetes, metabolic syndrome, alcohol abuse, and high carbohydrate intake. Since patients with hypertriglyceridemia are at risk for pancreatitis and they do need rapid reduction of triglycerides to reduce this risk, the use of fibrates, which preferably would be fenofibrate, niacin, and or omega-3 fatty acids will result in rapid improvement of hypertriglyceridemia. If patients will be on combination therapy with statins and fibrates, I highly recommend that you use recent generation fenofibrates in combination with statin, but gemfibrozil should not be added to statin therapy due to an increased risk of myositis and rhabdomyolysis, and you may recognize gemfibrozil as lopid. So the combination does result in increased risk of myositis and rhabdomyolysis. There are other patients that may be candidates for non-statin therapy, and that includes those who cannot tolerate statins and those who do not achieve the expected statin response, or those who are at high risk, those with established cardiovascular disease, familial combined hyperlipidemia, or diabetes. So it's important to remember that the other agents have failed to support the secondary endpoints of reduced cardiovascular risk. Okay, so let's look at the pharmacologic options for treatment of hyperlipidemia. As mentioned, HMG-CoA reductase inhibitors or statins are the preferred therapy. They have proven risk reduction for cardiovascular disease. They are effective, they're inexpensive, there are several generic options, they're generally well tolerated, and there's really a small risk of side effects, most commonly myopathy and elevated liver transaminase. And we'll discuss this in a little bit more depth. So who should be placed on high-dose statin therapy at onset? High-dose statin therapy is recommended in patients who are aged 20 to 75 to reduce atherosclerotic cardiovascular disease. And high-dose therapy will result in an LDL reduction averaging about 50%, depending upon the agent chosen. Appropriate agents to achieve this reduction include atorvastatin, 40 to 80 milligrams a day, or rosuvastatin, which is a newer agent, also termed Crestor, 20 to 40 milligrams a day. So who should be treated with a high-dose statin therapy? That includes those with established cardiovascular disease, and if they're less than 75 years of age, this is a level A recommendation. Patients, primary prevention patients with very high LDL values, greater than 190, and this is also a level A recommendation. Primary prevention in adults aged 40 to 75 years of age with an LDL between 70 and 189 and have a 10-year estimated cardiovascular risk greater than 7.5%. Moderate dose statin therapy is also an option in these patients. I'll discuss this in a moment, but this is a level A recommendation. So basically, if patients can tolerate high-dose statin therapy, that would be the preferred method. If they don't tolerate high dose, you can move them to a lower moderate dose therapy. And then, of course, because diabetes is a cardiovascular risk equivalent, primary prevention in diabetic patients age 40 to 75 of age with an LDL also between 70 and 189 and 10-year risk greater than 7.5%. Now, moderate dose statin therapy is an option for some patients, and experts did address who would benefit from moderate dose therapy, which will provide a reduction of LDL averaging about 30 to 50%. Now, moderate dose statin therapy should be used for secondary prevention in an older population, so adults who are over age 75. And the reason for the moderate versus high dose, of course, is due to altered metabolism, increased risk of side effects in this age cohort, and often the presence of renal insufficiency. Primary prevention in adults age 40 to 75 with an LDL between 70 and 189 and 10-year risk of coronary heart disease greater than 7.5%, as we just discussed. Primary prevention in diabetic patients age 40 to 75 with an LDL between 70 and 189 and low risk of cardiovascular disease, their 10-year risk being less than 7.5%. So that would mean basically all diabetic patients between 40 and 75 years of age should be on statin therapy, whether they are high or low risk with the pooled cardiovascular risk calculator. And then, of course, patients who are unable to tolerate high-dose statin therapy. So the options and doses are outlined for you here. And note that these should be starting doses and not titrating doses. So we have several options: atorvastatin, fluvastatin, lovastatin, pitavastatin, pravastatin, rosuvastatin, and simvastatin. Okay, so there are certain categories in whom lower dose therapy may also be warranted. So low dose statin therapy will lower LDL an average of 30% or less. And appropriate individuals for low dose statin therapy would include those who are taking concomitant medication that would alter drug metabolism. For example, patients who are on cyclosporin. Think about those who have undergone solid organ transplantation. Those with complex medical regimens, for example, those receiving antiretroviral treatment for HIV, or those patients who are unable to tolerate moderate to high dose therapy. So low dose therapy options include fluvastatin at lower range, lovastatin, pitavastatin, pravastatin, and simvastatin. Patients who are intolerant to the recommended doses or who have less than an expected response really should be evaluated for adherence to lifestyle and medication, and should be evaluated for secondary causes of hyperlipidemia. And this should be for all patients who are on either low, moderate, or high-dose statin therapy. So a couple of considerations I want you to think about, and that is it's really important to know your prescribing information. All statins are not created equal. They differ in terms of their potency, metabolism, clearance, drug interactions, and cost. Now, there are some agents that are not significantly metabolized by cytochrome P450, and hence they're less likely to have drug interactions. That would include pitavastatin, pravastatin, and rosuvastatin. There are other agents who are metabolized by cytochrome P450, specifically by CYP3A4, and this includes atorvastatin, lovastatin, and simvastatin. Atorvastatin it has less chance of having an interaction, but lovastatin and simvastatin do have higher interactions and risk with amiodarone, macrolide antibiotics, azoles, protease inhibitors, cyclosporin, and those who consume high amounts of grapefruit juice. So please be cautious in these patients. Personally, I do not prescribe a lot of fluvastatin, and this is not to discourage you from doing so, but it is metabolized by CYP2C9, and it may have interactions with 2C9 inhibitors, such as phenytoin or dilantin, glyburide, and warfarin. So, in terms of ACC/AHA guidelines, the guidelines also addressed how we should be initiating and monitoring statin therapy. So let's take a look at that. So in all patients, they should have an ALT checked at baseline, And the guidelines recommend repeating liver function tests as clinically indicated. There's actually not a recommendation to check them routinely. I will say that personally, I do check them in the first 4 to 12 weeks at the same time that I check the fasting lipid profile. Patients who are going to have elevated liver transaminase generally have these early in the course of therapy. So patients who have been stable on statin therapy for many months are unlikely to have an increase in liver function test. It's also important to document pre-existing myalgia before starting statin therapy to establish a baseline. Patients who are at high risk for myopathy because they have the drug interactions, which I just described, you may also want to check a creatinine kinase at baseline, and then of course repeat if they are symptomatic on therapy. The recommendation is to check a fasting lipid panel 4 to 12 weeks after initiation of therapy or after a change in dosage, and then to check the fasting lipid profile every 3 to 12 months as clinically indicated. If patients are going to be on combination therapy with a statin and fibrate, make sure you check a creatinine and an estimated GFR in these patients. Patients who are on therapy may have significant reductions in their LDL values. And we really just don't know how low is too low. But you may want to consider a statin reduction if LDL values are less than 40 milligrams per deciliter. That's really the kind of low estimated cut point. If you have patients that do not have the estimated reduction of LDL between 30 and 50%, consider a lack of adherence. And it's really important to educate patients on the importance of taking medications as prescribed. And of course, with the incident diabetes, please do monitor per screening guidelines. So let's talk a little bit more about statin myopathy. Statin myopathy is the most common cause of statin intolerance. It may occur in up to 30% of patients taking a statin. It does depend on the statin, and it also depends on whether or not they're on combination therapy. The risk factors for statin myopathy include elderly patients, especially those over 75, and hence the recommendation, even in secondary prevention patients, to be on moderate dose statin therapy. Those with smaller builds, those with liver or renal disease, those on high dose statin therapy, vitamin D insufficiency, diabetes, presence of rheumatologic disorders such as PMR or corticosteroid myopathy, those with uncontrolled hypothyroidism, specifically with TSH greater than 10, and those on interacting medications including macrolides like clarithromycin or erythromycin, itraconazole, gemfibrozil or Lopid, cyclosporin, niacin, and danazol. Okay, so statin-induced muscle symptoms can range from weakness and cramps to myalgia with and without elevated creatinine kinase levels. Or it can be a more severe presentation such as myositis and rhabdomyolysis. Now, as clinicians, we must determine if the muscle symptoms are due to statin therapy or if they're attributable to secondary conditions. And so what you want to do is in patients who present with myalgia symptoms, you do want to check a creatinine kinase, or it's also known as CPK, creatinine phosphokinase. This is the preferred screening test in patients presenting with muscle symptoms. It's more sensitive and specific than transaminase, aldolase, or LDH because CK is prominent in skeletal muscle. Myalgia is the least severe and the most common presentation of statin-induced muscle symptoms. Patients will have muscle pain or weakness, but their CK levels will be normal without any elevation. They can be reassured and remain on statin therapy. Now, some patients may experience a mild CK elevation, which is unrelated to statin therapy. And it's just important to know that mild transient elevations of CK can occur following exercise. It's really common in high-intensity exercisers, including those who run. It can also occur in patients who are experiencing muscle cramping or during trauma, such as those who have just undergone injections or electromyography. Now, myositis is muscle symptoms with CK elevation up to 10 times the upper limit of normal. Once the statin is discontinued, and it should be discontinued, the CK will return to normal levels and there is no adverse long-term sequelae. In these patients, we will talk about how to reinitiate statin therapy, but statin therapy should be reinitiated. Patients may experience rhabdomyolysis and potential renal failure. This is the most severe and least common presentation. The FDA database has assessed the risk of statin-induced rhabdomyolysis, and has actually found a very, very low incidence of less than 0.5%. Another study I looked at rosuvastatin, which is the most potent statin and the newest statin, called Crestor. And it actually found in an FDA post-marketing analysis a rate of 0.2% for myopathy and 0.01% for rhabdomyolysis. So despite the rarity of the syndrome, you should be alert to its potential. Patients will report muscle symptoms and they will demonstrate significant creatinine kinase elevations greater than 10 times upper limit of normal, along with urinary myoglobin and renal insufficiency. Rhabdomyolysis is a syndrome. It results in skeletal myocyte contents like myoglobin, creatinine kinase, and uric acid being released into the circulation. And as I mentioned previously, it's more common in patients on combination therapy, especially in patients on statin and gemfibrocil, but there also are many other causes. Some studies have looked at CoQ10 enzyme depletion as a potential mechanism of statin-induced myopathy. And as such, I recommend the addition of CoQ10 supplementation in my patients who are taking statins, especially those with muscle symptoms. This is my personal practice. This is not a recommendation per the guidelines, and certainly further studies are required, but you may want to consider it in your patients who do experience myopathy. Okay, so what should you do if a patient experiences mild to moderate muscle symptoms during statin therapy? Do discontinue the statin until you can determine what the cause of the symptoms is and until you can perform a proper evaluation. At a minimum, you want to check creatinine kinase levels, and you may consider checking liver function test, serum creatinine, and a urinalysis. Of course, you want to evaluate for secondary causes of muscle symptoms, vitamin D insufficiency, and coexisting comorbidities. If you take the patient off the statin and the muscle symptoms or the elevated CK do not resolve after 2 months of being off the statin, you do want to consider other causes of the muscle symptoms, as the CK elevation is very unlikely to be related to the statin. If muscle symptoms resolve and no contraindication exists, you want to restart the patient on the same or a lower dose of the original statin to establish a causal relationship. If the causal relationship exists, then you can discontinue the original statin and use a lower dose of another statin. Once a low dose of statin is tolerated, then you want to gradually increase the dose as tolerated to the maximum effective and tolerated dose. If persistent muscle symptoms are unrelated to statin therapy or the predisposing condition has been treated, resume the statin therapy at the original dosage. Okay, so I just wanted to very briefly look ahead to some things that you may be hearing about. And first is PCSK9 inhibitors. PCSK9 is a new class, a monoclonal antibody therapy for hyperlipidemia, and it has generated a lot of interest this year at the American College of Cardiology 2013 scientific sessions. This new-to-class drug results in drastic reductions in LDL ranging from 55 to 76%. There is an ongoing large-scale mortality and morbidity study called FOURIER, which stands for Further Cardiovascular Outcomes Research with PCSK9 inhibition in subjects with elevated risk. And this study is going to be testing the composite endpoints of cardiovascular death, MI, hospitalization for unstable angina, stroke, or coronary revascularization. These results aren't expected till 2018, but stay tuned. It is going to generate a lot of buzz. I've also listed here some of the other studies that are related to PCSK9, and you may want to take a peek at this. So this agent, kind of where does it fit in? We don't really know the answer to this yet. It is more potent than even the high-dose statins. And the question about this medication is, how low is too low? We do know that patients who were born with this defective PCSK9 gene have really low LDL values, somewhere in the range of 20 milligrams per deciliter. They rarely develop coronary heart disease. And despite these very low LDL values, they don't have any cognitive or depression issues. So it may be feasible to drop our patients' LDL values to prevent atherosclerotic cardiovascular disease really without any secondary negative issues. But stay tuned about this new class, and hopefully next year I will have it for you. I thank you for listening to the presentation. As always, please contact me with any questions, and please don't forget to do the case study analysis following this presentation.